So moving on with the case, adequate nutrition is pivotal in Mrs. Tabulam's healing. It is important for the clinical nutrition staff to be involved with at-risk patients early on in their admission. Jen, one of our clinical dietitians, will explore the importance of nutrition in this patient population.
Great. Thank you very much, Cecilia, for that introduction. I just wanted to say how honored I am today to have been invited here to talk about this case study and to review with everyone the nutrition care of the hip fracture patient. So just to give an outline of what it is that I'm going to share with you today, first of all, I'm going to review my nutrition assessment of the patient. I'm going to review the impact of nutritional status on outcomes, strategies to improve nutritional care, and then at the end, I'm going to review my nutrition care plan with you. So first of all, I'm going to review with you the various components or the various factors that I look at when I'm doing a nutrition assessment on a patient. And when I go to speak to the patient, I try to obtain a detailed weight history and diet history. So when I go to talk to Mrs. Tabulam, I realize that she probably isn't the best historian, so I'm not quite sure if all the information that I'm getting from her is accurate. But from what I'm able to tease out from my discussion with her is that she has lost quite a bit of weight. Seems like it's probably been around 7 kilograms over the past 4 to 6 months. That works out to be a 13% weight loss, which is actually considered to be a significant weight loss. So that puts her BMI at 17.6, which is below the healthy range. I find out that the weight loss is likely related to just poor appetite, poor oral intake, as well as difficulty chewing her food due to loose-fitting dentures. When I ask her about her oral intake, she tells me that initially that she's eating 3 meals a day, but then when I probe her further, I find out that her meals are really like snacks, like mainly tea and toast, which is very typical of a lot of frail elderly ladies. She tells me, though, that she has been consuming about 1 bottle of Ensure a day because she has noticed that she's had some weight loss. And then she consumes around 2 servings of dairy a day. So she gets in about a glass of milk a day as well as a serving of yogurt. So when you see at the bottom of the slide there, you can tell that her dietary intake of calcium and vitamin D is below the recommended levels. So I just wanted to review with you some of the nutrition-related lab data that I tend to go over when I'm seeing patients similar to Mrs. Tabulam. So I would have also, in addition to what's on the slide here, I would have also looked at her electrolytes, her renal function, so her urea and creatinine, just to see if she's dehydrated or not. So after I reviewed that, I realized that she seems to be in a fairly good hydration status. So prealbumin and albumin are quite important, and I'm sure many of the staff here who I work with see me ordering prealbumin and albumin all the time on the charts. But they are important measures that we look at when helping to determine the nutritional status of our patients. So prealbumin and albumin are synthesized by the liver, and albumin has a half-life of around 21 to 23 days. So it gives me an idea of what a patient's nutritional status has been like over about the past month. Whereas prealbumin has a much shorter half-life of around 2 to 3 days. So that gives me an idea of what a patient's current nutritional status is like. I also look at C-reactive protein, especially in a patient who has a pressure injury. So CRP is a measure of inflammatory status. So it tends to increase during states of inflammation, especially in patients that have pressure injuries or deep tissue injuries. But we need to interpret the albumin, prealbumin, and CRP all together. So prealbumin and albumin are negative acute phase reactants, so that means that those values tend to falsely decrease during states of inflammation. So when looking at this patient's albumin and prealbumin levels, they're probably low because of malnutrition, but we also must keep in mind that the CRP is also playing a role in it. So when looking at her vitamin D status, so it's 40 nanomoles per liter, so basically deficiency is possible, but it's just not in the ideal range that we would like to see for this patient. So ideally, we would like her vitamin D level to be greater than 75 if at all possible. And in terms of blood glucose control, I'm actually satisfied with the blood glucose control of this patient. I think if we were to have tighter levels of glucose control, it would actually put the patient at risk for hypoglycemia and probably further falls. So another part of our nutritional assessment, and this is a part that dietitians are actually starting to incorporate into their assessment, it's just looking for some physical signs of malnutrition. So in the case of Mrs. Tabulum, I noticed that she has some hollowness and dark circles under her eyes, indicating that she could have some subcutaneous fat wasting. I see that she has some muscle wasting around her temple and around her clavicle region, and she's telling me that she just doesn't have the strength that she used to. So that tells me that she probably has some muscle wasting related to her nutritional status. And then other considerations would be her Braden score. And that's important for me as a dietitian because the nutrition component of the Braden score can give me an idea as well as to how the patient is doing. And then, of course, I would take into consideration the fact that she has a deep tissue injury. So the type of nutrition assessment that I've just reviewed with you is called subjective global assessment. And based on my assessment, I determined that Ms. Tabulum is moderately malnourished. And so the reason why she's moderately malnourished is because she's had inadequate oral intake, she's had quite a significant weight loss, she has evidence of malnutrition in her blood work, and she has some physical evidence of wasting. So just a point about subjective global assessment. So it's an evidence-based form of nutrition assessment that's the gold standard to diagnose and rate the degree of malnutrition, so mild, moderate, or severe. And this is used by nutritional professionals in Canada, Australia, and Brazil. And this form of nutrition assessment is something that clinical dietitians across the province are starting to implement into their practice. So this is a question that I have for the audience. I'm just wondering, what percentage of patients admitted to Canadian hospitals are malnourished? I can't, I couldn't really hear any of those responses, but 30%. 30%? Okay. 50? All right, so it seems like we're all over the place here. So the answer is 45%. So about half of our patients that come into hospital are already malnourished. And this is also similar to the rates of malnutrition in hip fracture patients. Oops. So what causes malnutrition? So basically, it's an imbalance of energy and protein. So during the early stages of malnutrition, the body uses stores. So it uses glycogen, fat, and protein stores and breaks that down as for energy in order to preserve muscle mass or lean body mass. But once those stores get depleted, then the body starts breaking down muscle into energy, which leads to muscle wasting. Other considerations is that there is an age-related muscle wasting that occurs anyway, so about 1 to 2% a year after the age of 50. And unintentional weight loss and muscle loss contributes to frailty in the elderly population. So in the case of Mrs. Tabulum, she likely has some age-related muscle wasting or sarcopenia with muscle wasting related to malnutrition on top of that. And exercise is really important because it's needed for amino acids to synthesize protein. So here are some hospital malnutrition facts. So the Canadian Malnutrition Task Force, which is made up of nutrition researchers and clinical nutrition experts from across Canada, did a very well done study that involved Canadian hospitals from across the country. And this was done in 2014, and it was called, the name of the study was called Nutrition Care in Canadian Hospitals. And there was a lot of data that came out of this study, and also some very worrisome statistics as well. So what we know is, of course, there are a number of patients that come into hospital malnourished, but the degree of malnutrition worsens during admission. Malnutrition leads to a longer length of stay by about 2 to 3 days, and there's a higher risk of hospital readmission within 30 days. So malnourished patients stay around 53% longer in hospital and have 55% higher medical costs. So similar findings are in the literature specifically related to hip fracture patients. So not only are malnourished hip fracture patients have higher readmission rates, they also have higher rates of reoperation. So next I'm going to review several studies, but I just took the most relevant information out of those studies and I'm going to review those with you right now. So what a lot of the literature is pointing towards is that malnutrition is a predictor of outcomes in hip fracture patients. So there have been several large-scale, well-conducted studies looking specifically at the relationship between albumin levels and outcomes in patients with hip fractures. So what the research is saying, about 45% of hip fracture patients have low albumin on admission, which is the same percentage of patients admitted to Canadian hospitals with malnutrition. So low albumin increases the odds of postoperative complications and mortality, such as complications related to congestive heart failure, COPD, diabetes, renal failure, and that's just to name a few. Low albumin increases rates of, has been shown to, patients with low albumin have increased rates of sepsis by 6-fold, and patients with the lowest albumin levels have an increased length of stay of 4.9 days compared to patients with normal albumin levels. And I just wanted to point out that the albumin levels that were measured in these studies were actually taken preoperatively. The research is also telling us that malnutrition is an independent predictor of 12-month mortality. And this was actually a really well done study that this fact came out of. It measured malnutrition using subjective global assessment by a registered dietitian. And another alarming fact when looking at malnutrition and outcomes It's been found that malnutrition is the most costly comorbidity and most likely to prolong hospital stay out of all inpatient comorbidities and complications in patients with acute hip fracture. So malnutrition also has a role to play in the recovery, the functional recovery in patients post-operatively. So malnourished patients are more functionally dependent and have a slower recovery of functional mobility post-op. And at 6 months post-op, malnourished patients have a slower recovery of ADLs. And patients who are malnourished or at risk of malnutrition have lower functional status at discharge compared to well-nourished patients, and they're actually less likely to return to independent living. So next, I'm just going to focus our efforts on looking at the role that nutrition plays in wound healing. So as Sheila pointed out in the last presentation, nutrition does play quite a big role when it comes to wound healing. So what we do know is that malnutrition can prolong the inflammatory phase of healing and negatively impact the quality of wound healing and can increase the rate or the risk of wound infection. So nutrition is really important, and nutrition, there are various factors of nutrition that can impact the healing of a wound. So what I'm going to do with you is just review the role of some of the specific nutrients in wound healing. So energy is important. So it's important that patients have adequate energy intake so that they can have proper collagen synthesis, but also so that protein can actually be used for healing and repair. So what can happen is if a patient isn't getting in adequate energy, then the protein that they're taking in their diet is actually being broken down into energy rather than being used for healing and repair. So it's important that patients have an overall adequate energy intake. And then of course we all know that protein is really important for wound healing. Any of the losses from a wound, patients can lose a lot of protein through those losses. So protein is important for the proliferation of cells for collagen and formation of connective tissue. Another important component of nutrition and wound healing is hydration. So dehydration decreases blood volume, which ultimately decreases the delivery of oxygen, nutrients, and immune cells to damaged tissues. And we need to keep in mind that dehydration can be quite common in the elderly population. Elderly patients have a decreased thirst mechanism, so they can actually be already quite dehydrated before they even start to feel thirsty. So that's why it's so important that in elderly patients, when they're in the hospital, that we really encourage them to drink adequate fluids. And then, of course, micronutrients play a really important role in healing of wounds. So micronutrients are essentially just nutrients that our body requires in small quantities. That's why they're called micronutrients. So micronutrients have many roles, such as playing the role of an antioxidant. They have roles with connective tissue cross-linking, synthesis of granulation tissue, collagen formation, and they can be an immune stimulant as well. And I just wanted to talk a little bit more about the importance of antioxidants. So during the inflammatory phase of wound healing, high levels of free radicals are produced, which can damage healthy healing tissue. So antioxidants actually help neutralize these free radicals so that they're no longer harmful. So some examples of antioxidants would be vitamin A, C, E, and selenium. So now that we know that malnutrition definitely can impact the outcome of a hip fracture patient. So how do we address malnutrition? So the positive news is that there are a lot of fairly low cost, easy interventions that various professionals on the health team can help implement, and they will really help the patient a lot. So it's important to have a multidisciplinary approach. We need to create a culture of food as medicine on the nursing units, and we need to address barriers to nutritional intake. So I do have another question for everyone that's in the room. So what are some barriers to nutritional intake for patients in the hospital? So what are some reasons why our patients aren't eating as well as they could be when they're in the hospital? What is that? The food? Okay. But besides that, can you think of any other reasons why? Lack of appetite, dentures. Okay, can't reach the food. Exactly, yeah. So there are a lot of different barriers for why our patients aren't able to eat as well in hospital as they could be. Yeah, exactly. So these posters were actually developed by the Canadian Malnutrition Task Force, and it's really just to help emphasize the point that food is medicine, and you need to eat your medicine in order to get better and improve your nutritional status. So when we look at the slide, you can see that there are a number of reasons why patients aren't eating in hospital. So 69%, I guess, when missed food, they were not given a tray. So this is something that a lot of us, or some of us, can relate to, especially the nurses that are working on 3 East, who are working with the hip fracture patients. Patients come in and they're NPO for their OR, and then late in the day, like maybe in the evening after supper, we find out that they're not going to the OR. But then the supper time trays have already been delivered, so what are we going to feed the patient on the nursing unit? So this is something that I think we can all work on together and try to address this issue, perhaps having some availability of high protein, high calorie nutrition supplements on the nursing units to give to these patients when they find out late in the day that they're not going to surgery might be one intervention that we can do that will help these patients. Also, just patients not getting help with tray setup, or patients can't reach their tray, or they can't take the covers or open the packaging on the food on their tray. Those are some other contributing factors as to why our patients aren't eating. And when we look at studies where they looked at how to address some of these barriers, just having this multidisciplinary approach and making it kind of like everyone's responsibility on the malnutrition or on the multidisciplinary team, just to make sure that our patients are at least able to reach their tray and getting the proper setup at mealtime. And I do understand nursing staff are very busy on the units, but even just for the other allied healthcare professionals that could be in the room at the time that trays are delivered, just making sure that patients are getting properly set up would be really helpful. So I just feel that everyone has a role to play in this. So there have been some research studies done that looked at the effectiveness of a multidisciplinary approach in addressing this issue. So what was found that this approach increases energy and protein consumption by 200%. So it basically doubles a patient's nutritional intake. It also increases not only energy, protein, but other nutrients as well, intake of those within the first 7 days. There's less deterioration of nutritional status and more likely to be discharged home. Lower decline in quality of life 3 months post-op, and fewer malnourished patients overall post-op. And what the research is finding, and I think many of us can relate to this in the room, patients and staff place a lower priority on post-surgical nutritional treatment than on other interventions. So having this multidisciplinary approach helps decrease some of these barriers to nutritional intake. And then just treating nutrition as medicine engages patients and staff to put more of an emphasis on nutritional intake. So just to get back to what my role is as a dietitian in this patient's care, I want to review with you what my nutrition care plan would be for Alice Tabulum. So my goals for this patient would be to provide adequate energy and protein intake to promote healing and preservation of lean body mass. And also that she receive adequate micronutrient intake for optimal bone mineral density as well as healing of her deep tissue injury. So I would place her on a high energy, high protein diet. So my specific interventions would be a diabetic minced diet because of her chewing difficulties. I would order Resource 2.0, 60 meals 4 times a day, and that would provide an additional 500 calories and 20 grams of protein on top of what she's able to eat. And the reason why I would choose this supplement is because the nurses are able to give it out with the medications, so it does reinforce that whole cultural change as food is medicine, so patients see it, that it's pretty important that they take it. And also, when the nurses give it, they actually record if the patient's taken it in the MAR, which I find really helpful in determining whether or not a patient's meeting their nutritional needs. And also, research does show that intake of nutritional supplements does decrease overall rates of complications and wound infections and does increase albumin levels. There is a lot of evidence to support it, and even if patients don't drink all of their nutrition supplements, they are still getting in a lot more calories and protein and nutrients than they would be if they weren't taking the supplements. I would ask the diet tech that I work with to visit this patient for calcium-rich, high-protein snacks. I would also suggest vitamin D supplementation of around 1,000 international units a day. And just a note about vitamin D, many Canadians aren't getting in enough vitamin D in their diet. So one of the only significant dietary sources of vitamin D that Canadians have in their diet on a daily basis would be milk. So a glass of milk, I believe, has around 100 international units of vitamin D in it. But even if a person drank milk every day, they wouldn't be getting in enough. Other food sources of vitamin D would be like salmon, mackerel. There's probably around 300 or 400 international units of vitamin D in those foods, but those foods aren't foods that people eat on a daily basis. Plus, Mrs. Tabulum is an elderly lady. She probably spends a lot of time indoors, so she's not really getting any exposure to sunlight either. And I would suggest that Mrs. Tabulum continue to take her multivitamin with minerals. So how am I going to monitor my plan and determine that it's working, that I'm improving her nutritional status? So I would order albumin, prealbumin, and CRP weekly. I would keep an eye on her blood glucose levels. I would look at her adequacy of oral intake through collaborating with the diet technician, nursing staff on the unit. I would also look at her healing, or wound healing, or healing of her deep tissue injury. And I would do that through attending pressure injury rounds with our pressure injury team at Dartmouth General, as well as looking at some of the wound flow care sheets in the patient's chart just to look at the measurements. I would also want to take into consideration how she's doing with physio and how her functional status is coming along, and then I would suggest repeating a vitamin D level in 3 months. So just in conclusion, nutrition does play an integral role in influencing outcomes of hip fracture patients, And malnutrition not only increases length of stay and cost to the healthcare system, but more importantly, it negatively affects the quality of life and outcomes of our patients. So having this multidisciplinary approach is key to addressing malnutrition. And the clinical dietitian has a unique set of skills and knowledge to diagnose the degree of malnutrition and assess the nutritional needs of each patient based on the most current evidence. So my references. Great, thank you very much.